So good morning, good afternoon, everyone. Very happy to welcome you to this webinar live, especially for people from India, for which it's 6 p.m. local time, right?
Yeah, that's right.
That's right.
For people who are in Europe, this is more 2:30 p.m. like mine. My calendar actually 2:30 p.m. actually in Switzerland. So this is the agenda we're going to follow today. So I'm going to myself with a brief introduction of the company, what we are doing. Then we'll go to different presentation from three different doctors today. We're going to start with Dr. Mohan, and then after Dr. Mehta, then finally Dr. Kenya. And I will end up this session with a kind of an outlook with a presentation on active lens with electronic inside. This whole thematic will be around the IOL, on the EDOF, and then after on the what's next in terms of outlook. You have to know that this webinar will be recorded and will be eventually available on YouTube afterwards. If you have any questions, you can chat. You can type any questions. We'll be happy to answer them at the end of each session and eventually at the end of the final presentation. Starting with a brief presentation of our products. We are located in Switzerland, and the main goal for us is really to manufacture lenses for which we can restore the accommodation. And we're going to see today with the different testimonials from the three doctors that this is very using the pseudo accommodation. That's through the optical, and they will detail that, especially with extended depth of focus technology. And after we will end up with an active lens that will really go back to what we all want, meaning actively restore the accommodation. But that's really what we would like to address today. I will be very brief on the products we have. This is the portfolio from our company. And basically, we're going to focus on the product in the segment C called Lucidis. Lucidis is a monofocal plus lens that is like a monofocal, but have something in the middle that will create this EDOF, extended depth of focus, with a very particular technology. And we will be able to spend some time here to discuss about that later on with the doctors. We'll be happy to elaborate more at the end with the active lens. Having said that, I'll let the word to Dr. Mohan to continue on the presentation. Thank you.
Thank you, Dr. Max. My talk is on Lucidis IOL using P&DB optical principle. So we'll be talking about what is the P&DB optical principle. We'll be looking at it. In today's scenario, just doing a cataract surgery, removing the cataract and putting an intraocular lens will not be enough, because most of the patients are looking for something which gives them freedom of vision, which allows them to do whatever they want at any point of time. And so they want not only 20/20 vision, but they also want N6, they also want intermediate distance. So they'll be able to do their all the life activities without any need for glasses. So the need for developing newer IOLs is always there when such a demand has come. So first, let us look at what is the need for a multifocal or an EDOF lens. EDOF meaning extended depth of focus lenses. So we know that when we are young, we have an excellent accommodation range, which can range from 0 to 3.5. But as we age, our accommodation is lost, and as presbyopia sets in, slowly we lose accommodation. And at this point of time, when we develop cataract, if you remove the cataract, then you're going to replace only the distant vision correction. Someone is making noise in the background. So, so the best possible thing that we should do is we should find a lens which will take care of not only the distant vision correction, but also give us a good quality of vision as we would have had it when we were 40 years. So with that concept in mind, the accommodative lenses were developed. So the idea of these accommodative lenses where they move forward and backwards and try to mimic the quality of the crystalline lens. However, they were the precision was not very good, and they were not consistent, their performance. And the disadvantage was that with aging musculature, the entire forward and backward movement stopped, and the accommodative action also stopped. And though they had excellent distant vision, they could not function as multifocal intraocular lenses or accommodative lenses. So we had to look for other modality by which we can treat this patients who need intermediate vision as well as distant vision. So one option was to put a monofocal lens in both eyes, but correct the distant dominant eye for distance and the other eye for near. So by doing this, they created a blended vision by which they could see one eye, use one eye for distance and one eye for near. However, there was the quality of vision attained by this was not very good, and some of the patients were clearly very uncomfortable with this type of vision. And then came the multifocal eyewears, which is the second graph that you see here. And you can see that they had excellent distant vision and they had good quality, fairly good quality near vision. But there was a lot of gap between distance to intermediate and intermediate to near. And they again, the loss of accommodation between the intervals made the patient very unhappy. So then came, what is the need for intermediate vision? As we are going into this, we just need to know what is intermediate vision. Anything what we see at arm's length, like looking at a computer or driving in a car, looking at the speed, what we are looking at arm's length. These EDOF lenses were developed with the idea of improving not only the distant vision, but also creating a range of vision which would include intermediate vision as well as near vision. So EDOF meaning extended depth of focus, lenses with extended depth of focus. So the extended depth of focus, here you can see this is a distant vision curve, and then this is a near vision curve. And there are two types of lenses. One is the distant vision curve extending into the intermediate zone, and this one from the near vision, it extends into the intermediate zone. So it could go both ways, thereby trying to bridge the gap and creating a fairly decent intermediate vision the patient. So this looking at the different type of eyewears that we have in the market, most of the EDOF lenses that we have this type of curve. So this type of curve is, it starts from the distance and goes towards the intermediate distance. But there is a gap again, and then you get the near vision curve. Whereas the Swiss Advanced Vision eyewear, which we are talking about, had excellent distant vision, and they had excellent near vision with a curve starting from the near vision going towards the intermediate distance. What was the advantage in this was that it was a seamless flow. The patient did not really appreciate the gap between the distance and the intermediate distance. Because the curve started from the near towards the intermediate, the quality of vision that the patient had is much better than having the curve coming from the far to distance. So the different type of intraocular lenses, EDOF lenses that we have are the ones which are used by diffraction. This is the commonest lens that is being used today, and probably the highest lenses that have been used till now. So they have multiple focal points along the curve, and they did produce, though they didn't have many rings, still the chances of dysphotopsia was always there. So the next type of lenses use the spherical aberration concept. So basically, by creating a more prolate type of lens, they were able to increase the depth of focus. However, this produced a lower image quality and lower light intensity reaching the retina, and the near vision was not as good as it should have been. So then our new concept of pseudo non-diffracting beam, in which you can see this is the diffracting beam which comes to a point focus, and the pseudo non-diffracting beam showing an extended focus along the entire length of from near to distance. And this is just a line showing how a non-refracting beam looks. So using this technology of pseudo non-refracting beam, the new Lucidis lens was developed. So this is an animation which shows that this is an animation which shows, I don't know whether you're able to see an animation. So when the light comes into the lens, strikes the lens, and the transmitted wavefront gets converted into a pseudo non-diffracting beam. And you can see that from it has an extended depth of focus, starting from intermediate distance to the near distance. This continuous way of life has enough light intensity to reach the retina. So this was the advantage of the new type of technology using the PNDB protocol. So the benefits of this beam was the continuous vision from near to intermediate to distant vision gaps, which are less noticeable by the patient than near to intermediate gap. It allows the patient to perceive a full accommodation from near to distant vision without a noticeable drop in vision. And the quality of vision along the extended depth of focus was also much better than the other lenses. So when they compared this Lucidis lens with other lenses which are also EDOF, they found that the amount of dysphotopsia was much less and the quality of the image was very well maintained when compared to the other two lenses. The lenses which we are using now commonly is a diffraction lens. The advantage in these lenses was that there was a low pupillary dependency. However, the Lucidis lens at least needs a 2.53 millimeter lens, so it is pupil dependent. But when you look at the downsides, the only downside that we're looking at this lens is a hydrophilic background, whereas in the other type of lenses, there is a decreased image quality, lower light intensity when it reaches the retina, and higher incidence of dysphotopsia. Benefits are from near to intermediate, good accommodation from near to distant vision, constant quality of vision, no glares and halos, and no diffraction. So this lens, as you can see, is a 6 millimeter optic. The central portion of the optic has got an aspheric zone, which is about 1 millimeter. And through this aspheric zone, it creates a pseudo non-refracting beam, which is able to give good vision from intermediate to near. And also you can see the graph showing that at the 3 millimeter zone, the quality of vision for distance improves, and whereas the near and intermediate throughout whatever may be the pupil size, the quality of vision is the same. But it works best between 2.5 to 3, beyond 2.5 millimeters. So it is a little bit pupil dependent. So you cannot put it in very small myotic eyes. So coming to this, you can see the light distribution here in this lens. 52% is for this, and nearly half of the light goes for distant vision, and the rest is split between the distant, intermediate, and near vision. So at all points, the quality of light towards the retina is very good, and the patient's clarity of image is also very good. So this is a defocus showing a difference of about plus 1 to minus 0.1 on all these 25 patients, which are done over a period of time with very little defocus. So this is one of the first studies which was done, showing a clinical and agrometric evaluation of the new refractive intraocular lens with central extended depth of focus. And this was done on 158 eyes of 94 patients, and they tested the postoperative visual acuities in photopic conditions, which showed that at the end of 3 months, there was a definite statistical significant increase in the quality of vision in all parameters. This is a chart showing uncorrected near, intermediate, and uncorrected far vision, and the distinct difference between the pre-op and the postoperative visual acuity. Also, the best corrected visual acuity, near and far, also improved postoperatively. So the other thing that we were looking for was the spherical equivalent in diopters, and it showed that at least more than 50% of the 58% of the patients had plus or minus 0.5 spherical equivalent. And about 86% of the patients had plus or minus 1 at the end of surgery, at the end of 3 months. And the contrast sensitivity using the Pelly-Robertson chart was also excellent at the end of 3 months. So this is some of the patients that they looked at. They showed one patient had a haptic rupture, which caused a slight decentration of the lens. But however, you can see on the eye trace that the quality of vision still maintained. There is no aberration coming from the cornea and coming from the lens, the internal optics, and the patient maintained good quality of vision in spite of the slight decentration. This is again an advantage which is not seen in many lenses. So this is showing a slightly tilted lens, but the eye trace showing very minimal defocus or the aberrations arising from the internal optics. So the characteristics of these lenses are, it's a pseudophakic single-piece foldable intraocular lens on a hydrophilic platform. The optical diameter is 6 millimeter. It's based on the technology of pseudo non-diffracting beam. Power range is from plus 5 to 30. Closed loop angulation of 0 degrees, and it's available in 2 haptic sizes of 10.8 and 12.4 depending upon the size of the eyes, and it can go through a 2.2 millimeter incision. So I'm just going to show you a small video of my implantation. Someone, can you switch on video, someone? Yeah. The advantage of these lenses is that they are very easy to load. Very easy to load, just like any other lenses. The cartridge is a push type of cartridge, and that is also very user-friendly. It goes very smoothly to a 2.2 millimeter incision, as you can see. Another advantage of these lenses are they center very well because of the close loop. They center very well. And they're self-centric, so you really don't have to worry about the lens moving out of place. And you can see, if you look very closely, you can see the center is a very pasted zone. So that's the greatest advantage because there are not multiple zones. These lenses behave very well as far as the halos and glare are concerned. So we don't have halos and glare even in a fully dilated mesopic condition or scotopic condition, whatever may be. There is no glare on halos. And that's the reason why
Thanks a lot. We appreciate that. Thanks for the presentation. Sorry for the technical issue. We are about to solve that. Maybe a question to you, Dr. Mohan. You talk about hydrophilic, hydrophobic, and we talked about Lucidis with the near to far and far to near. But from your perspective, having this hydrophilic compared to hydrophobic, is it a disadvantage or an advantage? First question. And second, do you see the benefit of the near to far versus far to near? How do you see that?
The first question is.
The first question was we hydrophobic versus hydrophilic, with the PCO related to that.
The PCO rates are very high with hydrophilic lenses. We have seen this in the past. Almost by the end of 1 year, all of them will have posterior capsular opacification. Having said that, there are still some people who would like to do YAG capsulotomy for all these lenses very early, even in hydrophobic lenses. If the quality of vision goes down, the advice is you do a YAG earlier than you would normally do it. So looking at from that point of view, maybe it is not a disadvantage, but I would be happier in a hydrophobic platform, definitely. Hydrophilic, yes, it's a little bit of a downside to me.
Which is totally understandable. And we have chosen to do hydrophilic because it was much more easier for us to develop this new technology that you have very well described. Eventually, we can move afterwards to an hydrophobic in the future. That's something that...
Yeah.
Absolutely.
What was the second question? I didn't hear your second question.
The second was if you see from your perspective the benefit of having this near to far EDOF versus a far too near. I mean, theoretically, we have explained that, you have explained through that. Do you see that now in practicality for your patients?
Yes, because See, when you put a symphony lens, what we do is eye for distance and intermediate distance, and then the other eye, what we do, we put make it minus 0.75. So there's something called near vision. Because the near vision is not good with lenses. So we need to make one eye at least for near. So that's how we do this. So in these, in the Lucidis, bilateral vision, the quality of vision for near as well as for distance is very good. And the patient comfort is excellent. So that's what I find is a difference, because the other EDOF lenses, they work more for intermediate and distance, but Lucidis works for distance, intermediate, as well as for near. I would like to also ask the other panelists what they think about this. Dr. Kenya and Dr. Cyres.
What I feel is that having EDOF lens which is more dependent on near, because when we are putting these lenses, the patient is wanting near vision. That is the most important. And in other EDOF lenses, where just like Symphony, what Dr. Mohan said, the near vision is missing, so they are not that happy. But if you have one particular lens which is without rings, without those glare and halos, with an added dominance of near and intermediate, definitely it is a win-win situation, not only for the surgeon but also from the patient's perspective.
So this, I think you can hear me
all
now.
of us agree on that.
Yeah.
So we need to implement more and more of these lenses to actually
the two things that,
have a larger, because we have been doing Symphony for over several years. So we need to have a complete comparative data. We need to put in more of these lenses.
Hi, can you all hear me?
Yeah, Cyres.
Yeah. So, Sujatha brought out two very good points.
Any other questions?
One is that, should we do it on a hydrophobic or
Dr. Max, any other questions from anybody?
So Max.
As of now, Dr. Mehta is speaking. I mean, I don't know if you hearing.
So
Sorry for the sound
that,
issue we have.
Max, until Alcon came out with the AcrySoft platform and then had everyone say that it's 100 times better because it's hydrophobic and stuff like that, hydrophilic was always better, and hydrophilic is better even today. Hydrophobic is a good marketing gimmick, and they claim that they don't have posterior capsule opacification, which is a lie. And so if you say a lie 100 times, it becomes truth after some time. You pay everyone to say the same thing again and again, then everyone else believes it. The fact of the matter is that all multifocal lenses have...
I'm not able to hear. Dr. Kenya, are you able to hear?
And they need...
Dr. Kenya?
Yeah, we can hear your voice very well.
Sure. But what about Dr. Cyres?
A YAG capsulotomy
not able to
is...
just once at a time, otherwise we will be lost. Sorry. Dr. Mehta?
The YAG capsulotomy is always required, and I do it in all multifocal cases in 2 months. And the old studies where we used to do YAG capsulotomy and then we would get retina detachment and stuff is from the Stone Ages, when we used a gag laser like a Canon and blasted big holes in the eye. We don't do that anymore. We use very minimal energy because the capsule is tight already and hardly has any cells on it. At that point, we use so little energy that we do not get a retinal detachment. I haven't got it in years, and I've done thousands of YAGs at 2 months.
Yeah.
So having hydrophobic is perfectly fine. I think today, I don't have any financial interest. I wish I did. And I think that this is the best lens on the market today. It's better than the Panoptics. It's better than the Lisa trial. The patients see better. They don't get any glare and halos. I implanted somebody yesterday. They see perfectly fine today. And I don't have to tell them to adapt to glare and halos because they don't get any.
I think, thanks, Dr. Mehta. I think you're totally right. I mean, hydrophobic versus hydrophilic. At the end, the patient should see something positive. And it's besides the PCO rate, which maybe a little bit is different for sure, in the advantage of hydrophobic. But at the end, what matters is really what the patient can see. Dr. Mohan, we have a question for you. Can you hear us well, Dr. Mohan?
Yeah.
Okay, because sorry for everyone, we have a little bit of a problem with the sound. I think now it's getting better, which is good. So the question for you, Dr. Mohan, is about the injector. Can you give more information about the injector you are using for Lucidis implantation?
Yeah, it's a disposable injector which has been provided by the company. And it's very simple to load. It's not very difficult, just as you would load any other intraocular lens. And the advantage is that it goes through a 2.2 millimeter incision. It's a push type of injector, and it's very smooth. You need to load it with a viscoelastic, and it's very smooth, and the whole thing takes place in a second. So that's about it. It's not nothing which is unique about it. There's no lock system. There's no need to rotate your hands. There's not. It's very, very simple. It's just like a very simple device. So there's nothing more. I mean, I demonstrated to you how to load the lens, and just have to inject it. And again, the advantage of the closed loop system is it really centers the lens very well. That may be a very great advantage when you have a closed loop system, that the whole centration, you don't have to worry about it. And because of the centration is very good, the quality of vision for the patient also is likely to be very good in these patients.
Thanks a lot. Thank you. If there is no other questions, I don't see anything else so far coming on the screen. So if not, we can go to Dr. Mehta and with your presentation. So that's fine with you.
So, this gentleman called Ishtiaq comes to me and he says, Cyres, I'm going to start with a new EDOF lens. And I said, what's this EDOF? I never even heard of it, because we've been putting multifocal lenses for the last 20 years or so, since the array came out in 2000, 2001. We never heard of this extended depth of focus until Zeiss took out and the Symphony came, which was basically a low ad multifocal. It wasn't EDOF, it was just a multifocal with less ad. So now you had a multifocal lens where the patient would see distance and wouldn't bleed. So it kind of defeated the purpose in the first place. Let's start. So the basic issue is that no one wants to grow old anymore. In the olden days, everybody was happy to grow old and wear spectacles. Nobody asked for a multifocal lens. No one wants to wear glasses after cataract surgery. And you can see this elderly gentleman here bought himself a Lamborghini for his birthday. So nobody wants to compromise anymore. Hugh Hefner didn't wear glasses either. You see how happy he is? So today's patients expect surgery to provide them with vision quality that they enjoyed before presbyopia. In the olden days, when you operated somebody who was 60 years old, and then he saw as good as he did when he was 50, he was happy with that. But now when you operate when they are 60, they want to see like they were 20 years old again. So isn't a bifocal implant adequate for cataract surgery or a refractive lens exchange? Well, in the olden days, in the early 2000s, we had only refractive multifocals with a lot of glare, or then we had diffractive bifocals. So we had one or the other. And I was incidentally in America in 1999-2000 when Howard Fine was doing the FDA review for the array. So firsthand, I could see how unhappy the patients were with multiple images and glare. And the whole concept of neural adaptation came that, you listen to them complaining for 3 months, and after some time, they stop complaining. So that was the neural adaptation. So why have trifocal lenses gained popularity in the last 4 or 5 years? The key here is intermediate vision. Because if you're a pilot flying this plane, you don't want vision at 12 inches because then you can't fly the plane anymore. You need intermediate vision at 18 to 20 inches. So the concept of intermediate vision is very, very important to pilots, surgeons, people using devices. Until recently, the only option was diffractive trifocals on different platforms from different companies. Some of them claiming to be EDOF lenses they were just basically low ad trifocal lenses or low ad bifocal lenses. Now, the problem with the diffractive lens, what was wrong with the diffractive lenses is that they always reduced contrast. If you put a monofocal in one eye in a patient and you put a diffractive multifocal, bifocal or trifocal in the other eye, you will always reduce contrast and the patient will permanently complain that he sees darker in this eye. And there is no way to make that better. And he will go on complaining and complaining every time he comes that the eye he operated for a lot less money sees better than the eye in which you put the diffractive. So that's why you never put a diffractive lens in one eye, you put it always in both eyes. It always leads to glare and halos at night. And some patients are so unhappy that they come back and you have to explant the lens. They cannot see properly. I had a jeweler where I had put in diffractive trifocals from a famous manufacturer. And he was so unhappy. He said the color of the diamond changed and he couldn't see it anymore. So I had to explant the lens and put in monofocals for him. When we were basically doing okay in India because we had small pupils. So there was less glare and halos because at any one time, there were less rings that were exposed. But still at night, they do get glare and halos and they are rather unhappy. Then came along the eye-hands lens, and I put plenty of these lenses. And this is a good idea. It really does work. And some of the patients were 6x6 N6, no glare, no halos. And it was quite surprising how they managed to do this. So this is a good lens, I can tell you that. This 80 Lara lens, I put in plenty of these, and it's basically a low ad bifocal or trifocal lens, and it doesn't really do the job. It is not extended depth of focus, despite whatever they tell you. So this is the first real extended depth of focus lens where patients would see N6 the next day. And that's what I realized after I put in the first few lenses. Sujatha has already spoken to you all about the pseudo non-diffractive beam. I'm not really very technical, so I can't really explain all this to you. Max will tell you this stuff better than me. And the animation that she showed you, showing that the depth of focus is this long, and that's how it works. So let's see, from 2000 to 2020, I must have implanted more than 15,000 multifocals. And we implanted the array in 2001, the Restore, the M.Flex, the Technis, and the Acritech multifocals when the company was run by Christine Kreiner before they were brought over by Zeiss. And Lisa Tri and the Zeiss Multis and the iHands, and 10 different companies from India, Italy, Turkey, all making copies of one another. However, all the diffractive multifocals will give you glare and halos. There is no getting away from it. And I would say today, the best of the lot are the new EDOF lenses from the Lucidis lens and the Ziffy. That's also a good lens, and the iHands is superior to all the diffractive trifocals on the market. So I've put in 35 lenses from November. That's 17 bilateral and 1 unilateral, because the person had a monofocal lens in that eye and wanted some amount of multifocality. And the only way out, I didn't want to put a diffractive lens because it'd permanently be unhappy. I always do bilateral surgery with multifocals in 95% of cases. I tell patients that when you have a haircut, you don't cut half your hair on one side of your head, and it makes no sense to do surgery on one eye and not the other, and it's just silly when you can have a bilateral hernia and a bilateral kidney transplant, and you can certainly do a bilateral cataract surgery. 20 eyes were operated with the catalyst system, and the rest were just plain phaco emulsification. Some of these lenses were implanted for presbyopia in patients over 48. So my lower limit is 48, and a person less than 48, I will not implant any multifocal lens to correct presbyopia, because the vision they had without your lens will be superior to the one that you will give them after the implant. The youngest patient was 48 and the oldest was 76. And what's very important is correct patient selection. These are more active individuals who don't want glare and halos at all, but they will not shy away from reading glasses sometimes. Correct counseling of the patient is key to having a happy patient at the end of it. So you can show them really tiny print and say that if you expect to read this, you will not. So if you explain to them that things are going to be a lot better than they are, but you may still need to wear reading glasses for very fine print, they will be very happy with the outcome. At 1 week, we had 25 out of 35 eyes having uncorrected visual acuity at 6x6. Reading vision I always check with both eyes open, and we had 15 patients, that 30 eyes were N6 at just 1 week. And one patient was N8 and one patient was N10. And that's because we had a problem with IOL power calculation and became plus 0.75. And as you know, if you put in a multifocal and you have plus residual, the reading vision goes down. So 3 eyes needed LASIK. And I do this routinely. And I do LASIK for more than plus or minus 0.75 at 1 month, because I have access to my own excimer laser. So I don't have to pay anyone for it. So remember, if you do multifocal lenses, sometime or the other lens power calculation is going to go wrong, and you're going to have a laser machine to back you up. At 6 weeks, it improved to 31 out of 35 eyes, uncorrected 6x6 for distance, and 4 patients were 6x9. Distance vision in 2 or 3 patients like this, they always say, well, it's a little misty. And typically these are people who were 0 for distance and they were 48, 50 years old and were doing the surgery for presbyopia. When patients become 60 or 65 and develop visually significant cataract, they are always very happy with the result. The dicey cases are the ones that you operate between 48, 50, 52 years old when they already have pretty good distance vision. Let's have a look at the next slide. So what about the 35th eye? So he operated one eye with a Lucidis, and the other eye was a monofocal, and so he became 6x6 N8 in this eye, and he was 6x6 N12 in the other eye. So with both eyes open, his reading vision is better, but the important thing is he doesn't lose contrast and he doesn't get glare and halos at night. So this was my assessment. Patients who had significant cataract were subjectively very happy for distance and near, as the vision was poor before surgery anyway. Patients who did the implant purely for presbyopia correction did experience better uncorrected visual acuity for distance and near, but some of them did complain of ghosting around near print, and that reduced the vision in some cases to N8. These are people which I tell you before surgery, if you cannot see very small, you will still need reading glasses, then they are okay with it. So what about patients with a diffractive AT-LARA, EDOF and Symphony? I implanted more than 100 lenses of both of these in 2019, but I stopped because these patients had the same amount of glare and halos as a Lisa Tri or a Technis Multi, but they had poor reading vision. And more than 80% were N8 or poorer and had to wear reading glasses. And the company comes back and says, well, do micro monovision. If I wanted to do monovision, I wouldn't be putting in a multifocal lens in the first place. I'd just do monovision and save myself a pile of money. So I switched back to Lisa Tri and Panoptics. So if a patient is over 48 years, which is my lower limit, is okay with wearing reading glasses sometimes and drives at night, I will only implant Lucidis, Sifi or Eyehance now. If a patient refuses near glasses, even occasionally, it says, I will never wear near glasses, I only want to read books, I don't have any device and never drives, I will still put a diffractive trifocal so that they will end up with very good reading vision. So tips for success: ensure perfect biometry. Everyone who puts in multifocal lenses must have optical biometry. If you don't have optical biometry, don't put the lens. And you must have good corneal topography, and you must aim for cylinder less than 0.75, because wearing cylindrical spectacles after multifocal lens implantation defeats the purpose of the surgery in the first place. I always do bilateral surgery unless the patient is one-eyed. So what if a patient has cylinder? Then we must have a toric lens. We're not getting the Lucidis toric in India. We should. Residual cylinder blurs vision is unacceptable. And everyone says that they are going to use the laser LRIs to reduce cylinder. But I've been doing laser LRIs for 4 years now on the catalyst. And the effect does decay with time and your cylinder comes back. So the toricity of a lens never changes with time. So that's why we do need the toric lens now. Let's have a look at the video. Can we play the video?
Yeah, it's on its way.
Yeah. So this lens I implanted in November, just a box standard Phaco, nothing fancy here. A 5.5 to 6 millimeter capsular axis, simple Phaco emulsification, and that's the lens in the cartridge. This was right in the beginning when the lens and the cartridge were separate. So now it's a single piece disposable cartridge. It works very, very well. This was the initial lens, which came with a separate cartridge and a separate disposable injector. It's a large lens. It fills up the entire capsular bag. So I like to inject it a little bit slowly so I can get the leading haptic into the bag and then pop the trailing haptic in. So I feel that because this lens is large and fills up the capsular bag, maybe there's a little bit of forward motion of the lens with accommodation. Maybe Max can tell us about that. I'm not a scientist, I don't know. So this was, let's have a look at the next slide. Yeah. So remember that one happy presbyopia patient sends another. When he goes to the pub, when he goes to the club, and he's 60-year-old guy walking around without glasses, he tells all his friends, that, look here, you are all old people and you have glasses now. I don't have glasses, I'm still young. And that's how you get the next patient. So that's the end of the talk. And now you can ask me questions.
Well, thanks a lot, Dr. Mehta, for this nice talk. I think out of what you mentioned before, just a comment on there to support what you said, looking at the CFI and the Lucidis IOLs, which have something in common because they don't have any rings, and that's the beauty of that. And although they are CFI is using another principle, which is the aberration offset. Are using the PNDB, but at the end, what matters the most is that none of them has rings, and definitely you don't have these halos and layers that you very well described. So in that sense, it's very important that I think today diffraction is something to discard as much as we can to avoid this.
So luckily for the SAV IOL company, the Zifi is much more expensive than Lucidis in India, and Vaishal is also smiling there. I can see that. And I much prefer to put Lucidis every time and not burden the patient with having to buy a very expensive IOL to do the same job.
But that's a very important point you mentioned, because when I mentioned about the ABC product, C for Lucidis is meant to be the first affordable EDOF IOL. So from a price perspective, we want definitely to be at a price that people can afford to have a good vision. And that's really what we wanted since day one. Thanks for this item, which is very important. I think we have 3 questions. The first one was maybe for you, Dr. Mohan, or maybe for either 3 of you for sure. The question was, which size do you prefer for the average axial length? I don't know, Dr. Mohan, you want to answer that, or?
Yeah, so there are 2 sizes, and I'm not sure which one is which, but in the beginning, so the dealer in Bombay was giving me the first lens. I think he knows what size it was. Maybe Vaishal knows. And so I didn't get very good results with that lens because the biometry was off. So the size that I'm using now is better and works much better. So I think it's the smaller size now that we have. And that fits better in Indian eyes.
10.8 millimeter. Mm-hmm.
Yes. So the smaller one now, if you notice the earlier one, the first surgery, that was the first surgery that we did. That was the large lens, which completely fills up the bag like that. So I think Indian eyes are a little smaller, like we are all a little smaller in size. And so we need a slightly smaller lens.
That's correct, because we have developed the 2 sizes, the 10.8 millimeters and the 12.4 millimeters. So that's really up to the surgeon to choose then what's going to happen afterwards. Another question with regards to a problem with a small pupil. The question is, will that be a real problem with small pupil before surgery?
No, I don't think so. I've had a lot of patients with small pupils. I didn't face any problem that they could only see near or anything like that. I never had this problem. But I've only implanted 35 lenses, so maybe we'll have to implant more and find out.
We all know that small pupil can be an issue, because if it coincides with really the diameter of the bump of the cylinder, which creates the EDOF, which is around 1 millimeter, then that can become an issue, because the patient will only see at near intermediate. The far will be much more lower. That's the drawback. Yeah. We try to avoid
that. Distant vision will be affected.
Yeah, absolutely. Another question was, in case of bilateral implantation, do you aim for, or do you shoot for emmetropia, ODS, or mini monovision, like -1, 0.5 in the non-dominant?
Always emmetropia.
Emmetropia.
I totally agree with you, but that's better for you saying that. But that's every time the same thing we say. Just shoot for 0, shoot for emmetropia. Maybe last question before we go to the next talk. In case of complaints regarding the distance vision, would you suggest a monofocal IOL for the second eye?
No, never. So that's why I always operate both eyes bilateral, so that the question never arises and the patient can't compare one eye with the other.
No, but definitely I would agree with you on that. That's for sure. Especially for distance vision for Lucidis. I mean, that's where we are very strong from a distance perspective. It gives, that's a monofocal in itself. Huh?
When you buy shoes and you have 2 feet, you don't buy 1 shoe. When you go for a haircut, you don't cut half your hair. And so when you do cataract surgery, always do two together. Even Vaishal is doing that.
I will try with my hairdresser.
I have not started doing bilateral.
Yeah. Last question before we go to Dr. Kenya. How do you compare Lucidis to IANS?
If
I
you
think
ask
Lucidis
me,
has
I have
better
put
near vision.
Dr. Mehta, maybe?
Better near vision.
Lucidis has better near vision, and it's much better. Even glare and halos are virtually not there with Lucidis.
Excellent. Well, thanks. I think we can go to the next talk. That's going to be you, Dr. Kenya, if that's fine with you.
Okay. So, a very good evening to all. I would like to thank at the outset the Swiss Advanced Vision for giving me this platform to talk on the EDOF Lucidis. Cyres and Dr. Mohan have said that EDOF lenses are more popular nowadays because the restrictions in lifestyles are much lesser than the multifocal lenses. Gone are those days where we have to make the patient explain them and more chair time has to be spent about those rings and the glare and the halos. With this particular lens, my chair time is virtually no extra time is spent to explain the patient about the glare and halos because they're virtually not there. Today, intermediate vision has become more important. Today, most of our computer work, the iPad, and lot many things now we are doing at the arm length. So intermediate vision is the most important thing, and these EDOF lenses have primarily delivered us good quality intermediate vision. And with this latest generation, the newer generation EDOF, the Lucidis lens, which I call the EDOF without the ring, is very special. It gives an advantage over the eye hands that it adds near vision too. So if you have a lens which is able to see all three distances, the distance, intermediate, and near, without any downside of glare and halos, then definitely why would you choose a lens with rings? So today, the EDOF lenses, we have a spectrum of lenses today. The first came was the Symphony lens, the diffractive one with the Echelate design. But then came the SIFI lens, the spherical aberration one, and the Ihans lens, which has got a central lenticule of hyperasphericity, which they modulate the near or the intermediate vision. But all these lenses, the light modulation or the light intensity has not been taken care of. They have very low light intensity, and this makes it very, very difficult in low light situation. Though they are EDOF lenses, they are not able to perform that good in low light situations. Here is where the Lucidis lens scores over. The Lucidis lens, because of its instant focus technology and because of constructive the wavelength interference, there is less of destruction of light and there is more intensity of light which is given at the near and the intermediate. So even during the low light or while driving, EDOF Lucidus does not have much of a problem. So the new generation of lenses, one is Lucidus, the other SAV-IOL is an Eden lens, which is a lens which has got diffractive rings altogether. And to complete the list of EDOF lenses is a small aperture lens, but the most popular to my mind today is the Lucidus lens today, which is able to give distance, intermediate and near, and it's affordable. The lenses with the rings are not the lenses of future. The lenses of future are the lenses without the rings, so without any glare and halos. And the first generation of which was the IHANS, which was predominantly an intermediate vision lens. But the second generation lens, just like the Lucidis, was able to see for all distances. So the EDOF lenses without the rings are the Lucidis lens has set the trend for the few lenses of future EDOFs to come. Now this Lucidis EDOF has got a refractive aspheric pseudo non-diffractive beam based EDOF. And as my previous speakers have described the lens, I would not tell you more. What I was talking about is the Lucidis EDOF lens has two components to its what I would say why it is more better is one is a pseudo non-diffractive beam, and the second thing is the instant focus. It's a unique patented optical technology by which there is constructive interference of light, because as you know, the light moves in waves, and then when the two waves um, means they meet, the peak meets to peak, there is an increase in the intensity. There is no destruction of light, so the light loss is much lesser, and so it's a with much more intensity of light than the other EDOF lenses, and that is an advantage, especially in a dimly lit room. If you were to go in a restaurant where the lights are dim, it becomes really difficult to read the menu card. Here, the Lucidis EDOF definitely will score over the other EDOF lenses. Modulation transfer function of the Lucidis EDOF is in photopic conditions is almost 0.6. It's almost same as a monofocal lens. So in low light conditions at nighttime driving, it has no problems of halo, glare, even visibility is much better because the contrast is same as a monofocal lens. The light distribution is very good. It's almost 50-50 for distance and for near. And for smaller pupils, lesser than 3 millimeters, it would be the distant vision, as you said, would be slightly affected, a line lesser. So it may be 20-30 or 20-40, but the near vision would be still not affected with a small pupil. So my experience at Mumbai with the Lucidis lens has been, this is a retrospective study from Jan 2020 to March 2020. Before we went into a lockdown, we did 34 eyes. A comprehensive standard workup was done, and specular microscopy was also done. We did the surgical planning on the IOL Master 700, and we used the Virion image guided system for a visual axis centered capsulorhexis. And we use the Barrett's Universal 2 formula for all our IOL power calculation. So most of these patients were from 40 years of age to 65 years of age. And we have done a sequential bilateral implantation. We have not done simultaneous bilateral implantation, but we have just kept a 2-day difference between two implants of both the eyes. Astigmatism more than 0.75 was removed. Incidentally, I have put a Lucidis toric lens in India, and corneal guttes and pressures more than 22. All these were exclusion criteria. Angles alpha more than 0.8 was excluded.
We have lost you again, Dr. Kenya.
I have.
You here?
Yes.
We have lost you when you are talking about the alpha angle.
Yeah.
Yeah.
Alpha angle very, very important. Implanting the EDOF lenses and the multifocal lenses. Usually the norm is that angle alpha more than 0.5, you avoid putting that. But since these lenses do not have the rings and the central near lenticule is 1 millimeters, I have patients where I have implanted up to angle alpha of 0.8 and they have not complained of any glare and halos. So this is more moderate to angle alpha. We can be slightly more lenient to the angle alpha in these cases. So all these surgeries were done by me. We implanted this hydrophilic lens under irrigation. We did not use any viscoelastic, and under irrigation we could implant this lens beautifully inside the bag. So patients were examined 12 hours after the surgery and at 1 month thereafter. Post-operatively, they were given antibiotic eye drops for a week, and steroids, non-NSAIDs, and lubricating eye drops were continued for 5 weeks. We measured the uncorrected visual acuity for distance, intermediate, and near. And so overall data, we had 39 eyes, but we excluded 5 eyes for comorbidities and missing data. So what we are studying here is the 34 eyes, 12 subjects with bilateral implantation, and 10 subjects with unilateral implantation. So this was a preoperative data where the mean axial length is around emetropia, and even the K values are 43, 43. And if you see the angle alpha, if you see the range is from minus 0.4 to plus 0.8. So there have been patients on a higher side, more than 0.5, where we have implanted the angle alpha without any issues of glare and halos. I hope you can hear me.
Yes, we can, absolutely. Yeah.
Okay. Yeah. So the uncorrected visual acuity in almost 80.
Oh, we were able to. We just
3% eyes.
Sorry, Dr. Kenya, we have just lost you 10 seconds before.
Okay. So
yeah,
the uncorrected vision vision for distance on the slender it was 5/6, and 16% it was 6/9. On near vision 83% and N6 and N8, and this is uniocular measurement which I have taken of the near vision. This is the intermediate vision which we have taken, N10, N12, and N8. So most of these patients were N10 on the intermediate vision. So bilaterally, when we took the distant vision, near vision, and the intermediate vision, most of them had a summating effect. Means if one eye was for near vision N8 and the other eye was N6, it had a summating effect. If both the eyes were 6/9, they had a summation effect of 6/6 in both with binocular vision. So definitely bilateral, sequential bilateral implantation definitely enhance, and there is no requirement of neuroadaptation in any of these patients. Within the first week, they are back to normal. Their visual potential is almost 100%. So with the Lucidis IOL, most of the patient achieved excellent visual acuities for all distances, and those who were uncorrected 6/9 had a spherical equivalent ranging from plus or minus 0.5. So on giving that correction, they corrected to 6/6. But since the patient did not complain, we did not do any further procedures because their near vision was quite good. And most of these residual errors were slightly on a myopic side. So they were happy with the near vision. So we didn't touch them further. And the design of this lens is so good, it's so smooth, the blend, that there is no dysphotopsia. You question them directly. Also, the patient did not complain of any glare on halos. There was ease of night driving, computer activities, and reading activities, even in dim light, were very easy. This is unlike the other EDOF lenses, where the near vision is there, but the light intensity is much lesser. But with the instant focus patented technology of Lucidis, I feel that is helping them even in dim light. So defocus curve, if you can see, it has got a smooth range. So for distance, intermediate, and near. And the most important, interesting thing which I learned from my study was the angle alpha. The angle alpha even 0.8 of angle alpha did not matter for this particular lens. So this lens is very forgiving for a large angle alpha or a large angle kappa. This could be because of two factors. One is absence of rings, and the central near area is around 1 millimeters. So that is not affecting the lens in decreasing the vision or so. I would also like to quote the study of Professor Andre Marmud, who also showed that in his cases of decentration, the optical quality and the aberrations were not much affected. So this is a very forgiving EDOF lens which we have. And there is a binocular summating effect but that is true for most of these lenses. So Lucidis is a pseudo non-diffractive beam-based EDOF technology, which is very unique than the other lenses, and it is clear for all distances. And if I were to tell that if you can get an affordable lens at almost half the cost than an acrylisa, Zeiss acrylisa, why would you put a Zeiss acrylisa which has got rings and you have to explain the patient about the glare and halos? So I'm sure even Cyres would agree with me that if you have a lens which you don't have to, spend more chair time for glare and halos, and is able to give you good near vision, and which is tolerant to angle alpha, kappa, you need not measure much about it, and it's able to work even for low light with good contrast. I think it is near natural to natural vision, I feel, and Lucidis has achieved. It's a complete package of affordability as well as giving good distance, intermediate, and near vision. So this is my video. Incidentally, I have the opportunity to put the first Lucidis toric lens of India. If you can run the video.
Yeah, we're gonna do that in just 1 sec.
Yeah.
The good news is that we can hear you better and better.
Okay.
That's the good thing.
Yeah. This is the Virion imaging system which we have used, and I don't mark, I mark it with my keratome, the side of my keratome. We are just indenting the cornea with it. So this is hydro implantation of this lens under irrigation without any viscoelastic, and believe me, there is no endothelial damage at all. And the lens is big, it occupies the whole bag and centers very well, and there is no rotation which is seen with a toric lens post-operatively, which is very important for a toric lens, the stability inside the bag. So I go to my last slide. I thank you all for patiently listening to me, and I'm sorry for the interruption of sound. Thank you so much.
Thank you, Dr. Kenya. I think, sometimes you were just cut and I just mentioned it, so then you restart again. So I think everyone have a chance to understand the talk. Very
okay.
Thanks a lot. From a technical perspective, either Dr. Mehta or Dr. Kenya or Dr. Mohan, you described that very well. I'm just going to add from a technical perspective that this center works with the refraction. And you said interference, that's totally right. We're going to create interferences due to this portion of kind of a bump, but only by refraction. And then these interferences will create for the near and intermediate vision only the EDOF. But otherwise, that's exactly right. We have a couple of questions for the two of you, Dr. Kenya and Dr. Mehta. We can maybe start with that one about the sulcus implantation. And the question was, any experience with the sulcus implantation?
See, if you are implanting a multifocal lens in a PC posterior capsular rupture, then you would think about sulcus implantation, because this lens, the diameter is small. It's just 10.8, and I would not go in for a sulcus implantation even with a larger size of 12.4. For a sulcus implantation, you require an overall diameter of at least 13 or 13.5. We should avoid implanting this lens in the sulcus. That is my personal opinion. Because it can decenter.
Never.
That's very clear as a feedback.
Yeah.
That's very clear. The next question is maybe more for you, Dr. Mehta, for the PCO. The question is, what's the prevalence of the PCO for the IOLs implanted so far? I mean, for the two of you, actually, how many PCOs cases have you seen afterwards?
It's a very
50%.
short term. It's a very
50% for
short
the
term just evaluation. I think both of us have not finished a year of implantation. So this is too premature to opine about just now. But I have not still yagged any of my patient in the follow-up which I have of 6 months just now, of the oldest patient which I have followed up.
Yeah. And from your side, Dr. Mehta, it's really 50%.
Yeah, I try to YAG everyone at 2 months. And the reason for that is that I want to use very low energy, 0.81 on a Zeiss YAG laser system, so that the chance of getting retina detachment later when you will have to YAG them anyway will be nearly zero when you do it at 2 months. So whether I put in a diffractive lens, I put in Lucidis, I put in any multifocal lens from any company, at 2 months, if you really examine the posterior capsule under high magnification, it will never be as clear as surgery. And once you YAG it, the contrast sensitivity will improve, patient acceptance will be better. And I suspect that a lot of lenses which are minus 0.5 or 0.75 will sag a little backwards after a YAG capsulotomy done at 2 months, and not at 6 months or 1 year when the whole capsule's fibrosed. And even the little bit of ametropia that you have after surgery will be resolved. So
what I want to add,
do it at 2 months.
What I want to add is the Zeiss acrylisa trifocals or any panoptics trifocals. What you are talking about is a modulation transfer function in a range of 0.1 to 0.2, which is where even a very mild PCO would affect their contrast. And definitely, but this is a completely a new generation of lens where the modulation transfer function is almost 0.6. So it is just like a monofocal lens. So just like a monofocal lens, you treat it would be much better, because no matter anytime you breach the posterior capsule, there would be some vitreous changes, and those vitreous changes would liquefy the vitreous, and there is a possibility of a retinal detachment definitely. So in my mind, I would wait till there is a significant PCO, and this lens gives us an advantage of waiting, because here the contrast sensitivity will not get affected that much as in other diffractive multifocal lenses, where the modulation transfer function is very poor. It's almost 0.1 to 0.2, where even a very thin PCO, I agree with Cyres that even a thin PCO would affect the quality of nighttime vision particularly very much, but not with this particular lens.
Yeah, that's very clear. Thank you, two of you. Next question, maybe for the two of you as well, again for the pupil dependency. And the question is, what is the size of the ideal size of the pre-op for the pupil in mesopic conditions? Or what is the size which is excluded? Same thing.
3 millimeters would be good. 3 millimeters and above would be an ideal size. But in cases where the pupils are small, you can consider doing laser pupilloplasty if you want post-operatively. If you are dwelling on the borderline cases of 2.5 or low, you can think about doing the pupilloplasty. I've never tried it personally, but this is an option which I can think about.
Dr. Mehta, what is your opinion on the size
So
of
honestly, I never really thought about it. So I never measured any, and all 35 are so far okay. But now if Vaishal is saying, I will take a look at it now, and I will read all this modulation transfer function and stuff.
But it's a very important point, because as I said before, if that three coincide around with 1 millimeter diameter, it's really right away with the near intermediate vision only. Then the far getting being excluded, and that's not good.
But by doing a laser pupilloplasty, you can help these patients definitely.
Right.
If any patient complains of that, you can try a little bit of laser at the rim with the argon laser. You can just do it at the pupillary margin, just doing like an iridoplasty, which you do for plateau iris. You do have to do it at the pupillary margin.
what we have heard as well from other doctors that 1.5 or let's say 1.5 or 2 becomes really hard in terms of measurement. Then it's like, okay, exclude it from that field. Okay, next question specifically for you, Dr. Mehta. Could you compare Lucidis to Miniware?
Yeah, well, I've put in 6 Miniwell lenses, and all the patients are seeing just great. But the lens is quite expensive, so then I don't put it now, and I put only Lucidis. So
Same
if
here.
the Lucidis was as expensive as Miniwell, then maybe it'd be half and half. But if the lens is less than half the price, then there is no contest.
But thanks for that. I mean, that's again very key. We are totally aware of this affordability thing, which is something to take into consideration.
Also,
Absolutely.
the Miniwell lens is like a plate haptic. It's a single big haptic on one side and the other side. And sometimes it doesn't inject out very well. And the first case I injected the haptic core, but I positioned it anyway and it sat there. But I wasn't really very happy with it. So I think the Lucidis, initially they used to give us with the injector separate and the cartridge separate. And then I found that the Cyres cartridge and injector system work better. But the new cartridge that you're supplying, injector, works very well. I've
Very
first
well.
put water and I first put ringer, then I put viscoelastic. It makes it nice and slippery and the lens comes right out.
Excellent. Thank you. Last question, I think, from that session is for both of you guys. How do you select the size of the IOL? The 10.8 or the 12.4?
I only put 10.8.
Yeah, I also put 10.8, but ideally, if you're having a very high myopic patient, then you can check it on the UBN, the bag size, and that can help you. Otherwise, but that would be particularly more important for toric lenses, Lucidis toric lenses, where if you put a smaller size lens, the lens will rotate, and that is more important for a toric platform than uh, this particular platform, because over a period of time this bags would warp, and over a period of 1 month that difference would decrease. So putting a 10.8 millimeter lenses even in a myopic eye over a period of time would settle down. It won't affect much.
Yeah, it's very interesting for us because we are working with different countries, and it's really country or even doctor specific, the choice of the size. So it's some people are saying, okay, I only take into consider 10.8 or 12.4. It really depends, and I don't know if there is a kind of a common answer to that, but thanks for your feedback on there. I think last question before we go to the next thing is how easily can you rotate the toric Lucidis after implantation in the bag, meaning compared with other toric IOLs?
See, after implanting the toric Lucidis IOL, I could go behind the lens and wash the lens from behind also. Rotation was not a problem in this thing. Manipulating the lens is not an issue at all. Under irrigation, you can manipulate just like any other toric lens. Nothing unique about this lens about that. So being a hydrophilic platform, it's very easy to, it's malleable. It can rotate, but it is very stable. It doesn't move around, and it occupies the back completely. So that is an advantage of which I feel for a toric platform, that the rotation is lesser and the closed loop design of the haptic assists that, because the haptic capsular bag contact area is much more. So that is contributing to less rotation of the lens. So that definitely would help.
So it's easier to rotate than a plate haptic
Yeah, much,
and
much easier.
more stable than a regular lens with 2 haptics.
Yeah.
So it's halfway here and there, but that's why we rather put a 10.8 because once you put a 12 in the bag, then it just won't rotate. The entire bag will be rotating. Or like a plate haptic, you have to just keep 2 haptics out at the back and then turn it around and then put it in. But I never put any toric lens because I didn't know that they were available, and now I know.
Yeah, no, it's just very new. So it's just very new. So you will be able to implant those. That's for sure. Just a compliment on that, we have made a rotational stability to make sure that it's not going to rotate. And if you look at what's required on the norm, it's quite large in terms of angle, and we were far below. I mean, the study has demonstrated that we are like a couple of degrees of stability. So that was really good. So we are quite happy with that. Okay. Thanks, Dr. Kenya. Thanks, Dr. Mehta. If no questions, I think we can go to the last portion of the slides, which is actually me elaborating on the next generations of IOLs. I think three doctors today, Dr. Mohan, Dr. Mehta, Dr. Kenya, did elaborate on this EDOF technologies and sometimes others which are related to the same thing, not having any rings, which is really the game today to get rid of those halos and glares. But that's really good. That's what we call the pseudo accommodation. What we want to do is to go to the next level and propose really something new. And instead of having only a pseudo accommodation that you can see here on the bottom on the left with EDOF lenses, we want to go back to a real accommodation. And it can only be done using active lenses. The goal is really to go back to what the crystalline is doing. So for that, we have initiated and put a patent on a project called AirTask, with a smart device having electronic on it that will play different things to make sure that the crystalline is going to do, I mean, you're going to have the same thing as the crystalline is doing, but actively. The principle is very simple. It's like you have a tank in the middle full of liquid, actually BSS. That's what we have used for the prototypes, worked quite well. And you have an autofocus on the bottom, in the middle, that will detect in real time the distance of the object in the center of the picture you want to see. In this picture, to have a look and focus on the mountains, which are very far away, the system will be like flat. And if you want to have a picture that's going to be closer, I mean, social distance or even reading, the more you closed, the higher the curvature of the system will be. And it's meant to be due in real time. So really having this autofocus system, detection, and then having a real-time closed loop activity. Moreover, for that, we have to use a couple of energy mix. So we're going to use a mix between solar cells and induction. And the last thing is, as many devices in the world today, like pacemakers, like others, this device will be app controlled. So it means that for you, surgeons, or for everyone, you can act on your device after surgery without to go eventually to surgery twice, which is a very nice and important thing. You can kind of reset this device afterwards. So for us, this is really to set like the direction of the future. It's a project that we have started now 2 years ago. It requires a lot of funding that we are now looking at. And it requires a lot of time. You can imagine you have to have preclinical study, clinical studies. The prototyping itself is not that easy to do. But at the end, with the technologies we have today, this is something that becomes feasible. For us, it's very important as a company to not only to be at the edge with EDOF, and that's what we are right now, but really, again, to set the direction for the future, and to show that ultimately at the end, yeah, we have to go to active lenses to provide something which really mimic the crystalline. That was more about it for that section. Was pretty quick. I don't know if there is any question from people or any comments, or even comments from you, Dr. Kenya or Dr. Mehta, on this one.
Yeah. So when will we get this lens?
We'd love to have that like tomorrow. Realistically, if you look at the Gantt chart, it requires minimum 7 years, which are like 2 years of development of the device itself. We are now at the second prototype gen, and the rest is really the preclinical, the clinical, and the submissions and all tests. So 7 to 8.
Yeah, have you implanted this lens in a human?
No. We are really at the stage of the prototyping. That's really a lab lens, kind of a huge one, size 2, size 3, and it's not totally functional. But we are, by bits and pieces, we have demonstrated that it works, and now we have to fund it to make sure that now we can insert that into a size 1, and the preclinical, and then eventually with the clinical.
Okay.
There is one question here. Can we see any demo video of that? Yes, for sure. If you go to our website, sav-iol.com, there is a section called reference or resources, and then you can have a look at 2 videos about AirTask. That gives an idea about what we want to achieve. Okay, if no questions, well, I will close that webinar. Oh, there is another one. Okay, have you taken endothelial damage into account since this looks like an iris cloud lens? This is an iris cloud lens, absolutely. We know that it could damage endothelium, especially with the sickness. So this is something that we have taken into consideration. And we are still now at the design phase. This is something that we know, and we're going to take that into the design aspect of it. That's for sure.
You know, Max, you can think about making it a reverse iris claw. So you will not have any endothelial damage then.
Could be, absolutely. Well, the beauty of this project is that every time since 2 years, we describe that first, we have many doctors that wants to be part of the first clinical trials. That's one. And second, we have excellent feedbacks like this one or others, and that we're going to gather that. And we are here with humility to try to set the future, to have active lenses. But of course, we want to have a kind of a huge team around us to provide all the feedbacks and all the advice to make something that will be very efficient. Yeah. Okay, thanks a lot. I will close that one, this webinar. I will thank everyone. And it will be broadcasted, see you on YouTube. Thanks a lot.
Thank you.
Bye-bye.
Bye-bye.